하나, 둘, 셋. 안녕하세요.
Enjoying a cup of coffee while learning orthodontics the easy way. Easy Orthodontics Cafe, Ortho Barista, is back.
Congratulations, everyone, we have received an additional arrangement until December this year.
It's all thanks to the viewers who loved Ortho Barista. Thank you very much. We will continue to do our best to help you with orthodontic clinical trials with fruitful contents.
Starting with hidden clinical orthodontic tips, we'll cover everything from clear aligners to retention device protocols, gathering the essence of orthodontic practice and sharing it with you.
Before that, it's time for our special moment at Ortho Barista. 1, 2, 3.
커피 한잔 할래요? 커피 한잔 할래요?
It's quite harmonious.
From today, we'll also be introducing sweet desserts that pair perfectly with coffee. First, I would like to introduce a special dessert that I brought all the way from Tongyeong. Ta-da! It's a sweet honey bread, perfect for our sweet little treat brothers.
I think it goes really well with today's topic and tips.
The honey bread was first made and sold at a laundromat in the Hongnam-dong area of Tongyeong in 1963. It was a snack made for sailors that could withstand the warm climate of Tongyeong and be stored for a long time without spoiling.
도노새 잠시만요. 도노새 구슬 도노새 구슬 죄송합니다.
Actually, despite its name, the honey bread doesn't actually contain any honey.
But there's one here that looks very glossy, smooth honey. What is this?
The texture comes from grain syrup. The sticky consistency is reminiscent of honey, which is likely why the dish is named likewise. The filling is made with red beans. These days, various fillings such as sweet potato, walnuts, and cheese are also used.
Now, I'm curious about the taste of Tongyeong honey bread. I'll try it.
Am I eating too? Shouldn't this be eaten with your hands? Oh, this way.
It's really delicious.
Let's just do desserts from now on, only desserts. I think it would go really well with coffee. This reminds me of the rice donuts from the past, you know? The ones we used to enjoy as kids.
Earlier, when I smelled it, it had that nostalgic scent.
I remember the bread my mom bought me in the early 80s.
꿀팁 얘기하는데 꿀빵 먹으니까 꿀꿀하네요.
For our first session, we'll be sharing hidden orthodontic clinical tips. It might sound like a very attention-grabbing title.
These are tips that aren't usually well covered in textbooks.
Throughout the orthodontic clinical process, there are various steps involved: bonding, space closure, extractions, debonding, and so on. We'll be sharing useful clinical tips for each of these steps. Today's first session will focus on bonding and debonding. In general, I won't be covering basic bonding techniques, since I assume you're already familiar with them. Instead, I'll talk about how to bond brackets when there are issues with antagonist or adjacent teeth. Additionally, we'll discuss bracket adhesion to prosthetic restorations depending on the type of prosthesis. Finally, I'll explain key aspects of debonding as well. The first issue is difficulty in bracket positioning due to antagonist. What kinds of cases can this occur in?
These days, IDBS and digital setups allow us to create jigs for positioning brackets in ideal locations. In the maxilla, this usually isn't a major problem. However, even when brackets are ideally positioned, if you ask the patient to bite down, they can sometimes fall off immediately. That's why considering antagonist during bonding, especially in the mandible, is crucial.
고려사항이 굉장히 중요할 것 같은데 저도
Since I don't have a definitive standard for handling this yet, I find it a particularly interesting topic.
궁금해하는 내용이긴 합니다.
Typically, this issue arises in cases with a deep bite. In Class 2 cases, a deep bite is often observed in the canine region as well. In crowding cases, we often encounter various situations. But when actually proceeding with treatment, there are many things that don't immediately come to mind. So today, I'd like to explain some of those aspects. With deep bite, we might bond brackets lower, raise the bite slightly, adjust the shape of the brackets, or use smaller appliances. I'll briefly explain these approaches with real case examples. Right now, this is a slight Class 2 case. As a result, the canine cusp has experienced significant abrasion. Nevertheless, the deep bite makes it difficult to achieve proper bracket positioning. In that case, please mark it a little lower.
Normally, the bracket should be placed high.
I wasn't given a notebook for this demonstration.
Yes, it was placed over there.
Anyway, in this case, the bracket is bonded slightly lower. However, even with nickel titanium wire, a step-down bending adjustment may be necessary. Once the alignment is sufficiently improved, rebonding is performed later. This is one possible approach. In cases where the teeth are locked in position, raising the bite is also an option. We usually use a device called posterior bite block or PBB, but it's quite cumbersome. In fact, we need to take impressions and send them to the dental lab. So, we sometimes proceed by raising the bite at the 6th and 7th teeth. Looking at the process, according to the routine procedure, we use 014 and 016 nickel titanium wires and create space with an open coil using SS wire. For children, I often don't use bite blocks.
Right, children's teeth tend to move easily, and it seems like they transition well.
But the bite force might be a bit different.
Recently, there was a patient whose severe bite was interfering, and the mandible was raised about 10 millimeters. There was no other way to address it, and I always feel bad about it. Raising the bite is generally something we avoid, but it's good for children. However, not for adults.
It's a bit more uncomfortable, don't you think?
Maybe I'm just overthinking it, but most patients adapt well. However, the ones who had their bite raised more than 10 millimeters were really complaining about it to me. They kept asking me to take it off. So, in some cases, I had no choice but to proceed.
I usually observe the discomfort, and if possible, I tend to raise the bite a bit more. If they tell me it's uncomfortable, I lower it a little each time, which isn't necessarily comfortable. But they seem to adjust well.
It's better than before.
Those kinds of things, well, maybe they aren't really hidden tips. But anyway, by using something like a bite block to remove the locked teeth, and since the period isn't that long, I don't think there will be major issues like TMJ problems or TFO issues. If there are concerns like periodontal issues or mobility problems, using PBB or such a device could be a tip.
TMJ or periodontal concerns are definitely important factors. It's not common, but I always make sure to inform my patients.
That's right. When using a bite block, you can use various resins, and the material you see here is the Ultra Band Lock from Reliance. It's originally used for bands, but since the bite block is blue, it's also used for that. Do you usually use it?
Yes, I use that one a lot.
It's a bit expensive, so I also use local products like blockout resin or blue resin when using bands. I think there's not much difference in material properties, so you can use those as well.
Why is the resin bite colored blue?
It's visible when removal.
If it's close to the color of the teeth, it becomes really hard to remove.
But then, thinking about it, I wonder why it's specifically blue.
There's also red.
And I'm not sure why. Anyway, I'll look into it. It seems to be used in blue. Next, in cases of scissors bite, deep bite cusps, or when the teeth are locked in the back, there can be contact with the buccal cusp. So, sometimes I trim the bracket wings a bit, or I tell patients that I'll reshape their teeth and adjust some sharp cusps.
Is this what you mean?
Yes, that's right. Thank you. The next step is bonding with small devices. In fact, there are many small devices. Overall, when there is a deep bite in the maxillary anterior region, it becomes quite difficult to bracket the mandibular anterior teeth. Once the maxilla is arranged to some degree, the treatment period gets longer, which can be a bit challenging. So, I mentioned the PBB device earlier. Typically, when the bite is deep, we use devices like ABP. Also, in cases like ID, we sometimes use them. As shown here, smaller devices can be used, such as mini tubes, or devices like the A1 Smart Bracket. With this, of course, later on, we can switch to the brackets we're using for repositioning. Personally, I've shown the A1 bracket before. Initially, I inform the patient that we'll switch it later, and since it's small and not very noticeable, I suggest we use it. However, there have been cases where we end up finishing treatment with that bracket. It turns out to be quite useful. Some of you may be seeing the A1 bracket for the first time. It looks like a machine, but the profile is low, so it can be a very useful bracket.
Next time, I'll probably go over it in more detail. I have a question. Don't be too nervous. But when you're bonding, do you place the brackets in the ideal position and then raise the bite? Or, if the mandibular molars are too deeply crowded,
Personally, I use ABP a lot. In the past, when there's slight locking in the molar region, I just go with the ideal position for a couple of months, then raise the bite.
So, when placing the brackets in the ideal position, I place all of them first. I don't know if this is the right way, but I think it could be a valid approach. Even if it's placed lower, I think it leads to repositioning later on.
Yes, I think that's okay, too. I don't know which one is the right answer, but is there even a right answer? So, for those of you doing this, as we discussed in the first semester, when bending the wires, you need to be careful about things like bracket detachment. Next, let's talk about adjacent teeth and occlusion. This is about positioning the brackets due to adjacent teeth. Could you explain that?
The most common concern is the antagonist, and with adjacent teeth, it's more of a matter of choice. So, there are about 3 options. First, whether to create space and then place the brackets, or whether to place them wherever possible and adjust later, or, similarly for occlusion, we might use mini tubes or 2D brackets initially, then switch to the device we intended to use later. These seem like the 3 main options. This is quite common. When you need to place the brackets in the middle but there's no space, you first widen the space to place the device, or in some cases, whether it's an extraction or not, you need to plan according to the situation. Even in extraction cases, I might place the bracket at the end first and later replace it with the device I originally intended to use. So, I usually use temporary brackets that are a bit easier to remove. Here, I used metal brackets, but resin brackets also have a cost advantage and are easier to remove. Metal brackets are similar, but ceramic ones can be more difficult to debond, so I tend to use resin brackets more. Also, in some cases where it's hard to place brackets, I might use mini tubes or partial braces, and sometimes I can even split them in half. With various small devices, I first place them and then replace them later. If there's no space, I can use small devices or 2D devices that are used for partial orthodontics. These methods make the process easier. For occlusion, you can ideally raise the bite and place the brackets, but when adjacent teeth are involved, you can't place them ideally. So, whether you create space to place them or just place them somehow, it depends on the situation, and it's good to think through the options carefully before proceeding.
Next, bracket bonding isn't just limited to teeth. We also bond to extensive restorations like metal, ceramic, or zirconia prostheses. You're probably familiar with the basic processes for metal and ceramic brackets, so I'll skip over that part. Let's talk about temporary crowns, zirconia bonding, and fixed retainers. Oh, they keep coming off and causing problems.
There's still no perfect solution for this.
Let me share some tips on material properties. First, let's talk about temporary crowns.
In most cases, resin temporary crowns are commonly used. Usually, people use resin for temporary crowns, but if the orthodontic treatment ends in a couple of months, it's not a big issue. The problem is that they break easily. When they break and you have to redo them, and then reattach the device, it's a huge hassle.
The brackets don't come off, but temporary crowns falling off or breaking is very inconvenient.
So, if it's related to the molar region, and you need to do orthodontics and also a crown, I usually go with a metal crown. Then, I attach a tube, like for the 6th or 7th tooth. Personally, I use a welder to weld it. However, if the thickness of the buccal area is too thick, welding doesn't work well, so you need to ask the lab to make it thinner since the device needs to be attached. Also, if the curvature is too severe, the welding tube won't adapt properly to the tension. Of course, it can be bent a little, but the middle part is straight, so the shape needs to be modified a bit to make the adaptation easier. Once that's done, welding should work well. If it happens to come off inside the mouth, just use a regular metal primer for metal crowns, apply adhesive, and it will bond better than with zirconia or porcelain, in my experience.
By the way, do you use bands a lot these days?
I try not to use them as much, but when I was in training, one of the tasks for interns was to start separation for orthodontic patients and then band the number 6 and number 7 teeth as the first job after that. So, during my training, we basically banded all the 6th and 7th teeth. Do you still do that?
I personally try to avoid bands, but when finishing, band space can be an issue, so I tend not to use them these days. The reason I ask is because I don't have a bracket for banding. When welding a micro-etched bracket, the adhesive tends to be a bit weaker. So, what I do is either ask the lab to prepare the back of the bracket for welding or use something like greenstone in the clinic to slightly prepare the back of the bracket for welding. That could be a simple tip.
In my experience, zirconia crowns tend to fall off very easily, and while banding may be an option, I personally don't use it. It's better to avoid resin temporary crown as much as possible. But what about the anterior teeth?
Well, for the anterior teeth, you have to use resin temporary crowns, right?
That's right.
For molars, it's hard to do proper cleansing.
And there's a lot of irritation, so it's not ideal. I just wanted to point that out. As for zirconia bonding, I'm still not fully convinced about it. There are mixed opinions in various studies, with some saying it works well and others saying it doesn't. It's always been a question for me.
At the end of the day, we need to figure out the principles and processes for this. So, in general, for metal or ceramic surfaces, microetching is done, and then metal primers or ceramic primers and saline are applied, followed by adhesive bonding paste. This is the routine process. Now, in the case of zirconia, we do sandblasting at first. I usually do it for about 5 to 6 seconds.
But most studies recommend 10 seconds. In fact, if you spray that in the patient's mouth for 10 seconds, how do you put rubber dam on it and spray it for 10 seconds? And you have to put some suction on it. So, honestly, I spray it about 3 to 4 seconds.
10 seconds is longer than you think.
Because of the powder, there's a tendency to spray for about a second and then pause. However, the process actually requires more time than expected.
From today onwards, let's all make sure to do a full 10-second sandblasting. Also, using air suction will definitely help improve the procedure. Well, as you know, increased surface roughness leads to a larger surface area, which enhances bond strength. The same principle applies to other materials. For zirconia surfaces, a tribochemical coating, commonly known as cojet, can be used. I'm not sure how often you'll use this, but generally, when performing the procedure.
Oh, there's a small typo.
It should be cojet. Cojet essentially involves microetching, which increases the surface roughness. The heat energy generated during this process helps enhance the adhesion between the pre-existing silica coating and the underlying zirconia surface. This process is referred to as tribochemical coating. The routine process remains the same. The silica-coated aluminum dioxide, which appears pink, undergoes microetching for 10 seconds. The standard protocol is followed, but in the case of tribochemical coating, the surface is essentially ceramicized. So, whether it's a metal surface or a zirconia surface, using a silane porcelain primer is a useful tip. While reviewing research papers, we found that a strong rationale was needed for clinical applications. As a result, it turns out that using cojet tribochemical coating is more effective than just using a silane primer alone. As you'll mention later, MDP primers could offer even better outcomes, and we were able to substantiate these findings.
So, as mentioned earlier, bonding with zirconia crowns involves ceramicizing the zirconia surface. Silica particles adhere to the surface, making it more like porcelain, so we either proceed with a protocol suited for that or perform sandblast microetching. We roughen the surface with sandblasting and then apply a functional monomer to it. I've tried cojet in the past, but it didn't seem to work well, so I experimented with different approaches without understanding the exact issue. Recently, I've been using a functional monomer called G-Premio+. Some studies suggest that after microetching, using cojet is beneficial, but it's not necessarily required. If we roughen the surface with aluminum oxide and then apply an MDP-containing monomer, the bonding mechanism involves a chemical reaction between the zirconium oxide on the zirconia surface and the phosphate group in MDP. Theoretically, this leads to strong bonding.
But practically, the adhesion strength is often weaker compared to gold or metal restorations.
Even when following protocols precisely, bonding isn't always guaranteed, but it's also not entirely unreliable. That's why using a primer is an essential part of the process. Another crucial factor is saliva contamination. Zirconium oxide and phosphate groups are also found in saliva, so if the zirconia surface gets contaminated with saliva before applying the MDP primer, the phosphate group in MDP may react with the saliva's oxide groups instead of bonding with the zirconia oxide surface, significantly reducing adhesion strength. To ensure strong bonding, it's essential to minimize saliva contamination before applying the primer.
While this improves clinical outcomes, bonding techniques are not foolproof, and there's no single golden rule for perfect adhesion. Even microetching and sandblasting have their drawbacks, as irregular sandblasting can weaken bond strength, according to some studies. Additionally, oral conditions in a clinical setting are vastly different from lab environments.
Even if we simulate intraoral conditions in experiments, the human oral cavity is subjected to varied temperatures, saliva, and mechanical stress, which affects bonding performance. Since we can't perfectly replicate real intraoral conditions, there are varying opinions on the best bonding methods.
At this point, I feel like I'm offering explanations rather than tips, but ultimately, tribochemical bonding and MDP primers seem to be the best approaches based on the latest research.
But if even this doesn't work, what can we do?
In that case, we have to use bands.
If bonding fails, we remove the restoration and try again.
I usually warn patients in advance, mentioning that banding may be necessary.
Many clinicians who have recently started working with zirconia restorations face these issues, which makes sense given zirconia's rising popularity. Usually, after about 10 years, replacement becomes a possibility. But when a case is only 2, 3 years old, suggesting replacement can feel quite uncomfortable.
Now, moving on, this is still about bonding, but from a slightly different perspective. This time, I'd like to talk about bonding fixed retainers and some useful materials for that. Among the materials I've switched to, I've found some particularly effective ones, so I want to explain them briefly. It's simple. There's a product called Ortho Connect from GC. This is a routine paste used for bracket bonding, and it comes in 2 variations, one with a slightly lower flow and another, Ortho Connect Flow, with better flow. You can proceed with either as part of your regular routine. Both products only require etching, with no need for a primer, so you can directly bond. This reduces various oral environment variables, and personally, I've found it to reduce bonding failures and debonding rates, which is great. According to the manufacturer, the flowability is good, and when it hardens, it still has some flexibility, which helps accommodate slight tooth movement. This seems to enhance bonding strength as well.
I thought I was the only one using it, but you use it too? So, everyone's using it now. It seems like there are also similar competing products on the market. From what I know, there are situations where you suddenly need to remove the retentive liquid, right? For example, when one side breaks or when we need to remake something. When I use this for bonding, it really doesn't come off easily when I need to remove it. Usually, with flowable resins, a little tap and they break off easily, but this one doesn't. I thought, wow, this is great. Of course, it does come off eventually, but I've been using it for about 1.5 years now, and the debonding rate is definitely lower.
That's right. It's not like it never comes off. It's not easy to change the bonding for brackets, but I switched to Ortho Connect for bracket bonding as well.
It's a bit expensive, but if you try it,
you'll see it can be very helpful. The manufacturer claims that it saves on primer costs, so they say it balances out, but honestly, based on my experience, I feel like it's about 3 to 4 times more expensive.
That's right, when I calculated it, it seems to be about that much. Anyway, if you try it, you'll notice it has a somewhat soft feel, which might be helpful.
As you mentioned, the cost is one issue, but one of the biggest dilemmas or complaints we orthodontists face is patients coming in with their fixed retainers falling off.
It's not easy to avoid, and in terms of frequency, I'd say we get at least 1 or 2 such patients every day. We're still not at a point where it's 100% solved.
Here you see the Ortho Connect flow, which is a bit more transparent. This could actually be a disadvantage for visible areas. Finally, regarding debonding, Dr. Jamguk prepared the content for this video.
Actually, no one taught me how to remove the devices.
Didn't a senior teach you, Professor Kim Min-ji?
What did they say to remove it with? I've used a hard wire cutter, and it seems to vary depending on the type of bracket. Let me share the method I use among several options. As I explain this while watching the video, this plier, as I briefly asked you earlier, you use a pin cutter, right?
I've tried many different tools.
But I mostly use a bracket called Clippy C. There is also a special bracket made for it. But compared to that, I think the Damon bracket remover from Damon works better. It's a bit expensive, but I've gotten used to using it. Although it might not show up well on screen, I tend to remove it diagonally. When the bracket is positioned like this, and the wings are in this direction, if you just remove it vertically, the wings tend to break and it doesn't come off easily. So, I hold it diagonally and remove it, and it comes off better. When rebonding, it's heartbreaking if the device breaks. It needs to be replaced, but removing it diagonally like this seems to work better. Of course, even here, I tried it on number 22, and it didn't come off. I tried it like this, but it didn't come off, it stayed. There are cases like this, but if you hold it diagonally and remove it, the patient doesn't seem to suffer.
So, these are Dr. Jonguk's hands, right?
Yes, these are mine.
So in the case of the anterior region, Dr. Jonguk supports the teeth with his hands, and does it this way, but if not, it can be painful for the patient, so usually, I'll have them bite on cotton.
That's right. For the posterior teeth, it seems to come off easily. For the mandible anterior teeth, if you do it wrong, the patient might even scream. So, it's good to support it a bit and do it gently. Most of the time, this method works, though there might be better ways. I heard that Osstem also has a dedicated debonding plier. I haven't tried it yet. With tools like these, if you hold it at a slight diagonal, it should come off well, which is important because when rebonding, you want to preserve the bracket. Because of this method, I thought this video might be helpful.
The provocative title Hidden Clinical Tips of Orthodontics was presented alongside Honey Bread. Hope it was helpful. Today we discussed bonding and debonding. In the future, we'll gather and share more clinical tips that are suited to different parts of the orthodontic process. How was it today? It was our first broadcast. It was a little nerve-wracking, right?
Thanks to your kind support, we were able to add more content and prepare a lot of things. However, due to time constraints, there were some things we couldn't provide. So, I personally feel very proud that we can now include those in this newly scheduled broadcast.
In the next broadcast, we will talk about part of the correction, which we mentioned towards the end of our previous session, around episode 9. We talked about the principles and fundamentals. This time, we will actually focus on clinical cases, and as for partial orthodontics, Dr. Lee Jungkook is the one.
Oh, is that so?
You're becoming widely known now. Partial orthodontics part 2. We will prepare this in a fun way. Enjoy your afternoon. Thank you.
Thank you.